some of the things that we'll go over today that you'll have a better understanding is you will be able to understand the caries process, to detect caries visually, clinically, and radiographically, recognize risk factors and provide wellness counseling to your patients, which you guys are already doing in clinic, educate your patients in caries treatment and prevention, learn the important role of saliva, fluoride, and sealants, and classify caries using the GB Black classification guidelines. Some of the essential questions that might be answered by the end of today's lecture is it possible to eliminate dental caries? How are caries related to your diet? What role does saliva and fluoride play in caries prevention? And why are regular dental visits essential to caries prevention? And most importantly, what is the hygienist's role in dental caries prevention? Sometimes I think hygienists feel like, okay, well, cavities, caries, that's the dentist part. You know, we work on calculus and gum disease, and we don't really need to worry about caries. But it is important. It is a very critical role for the hygienist to have a background knowledge in caries, be able to recognize it, and help advise the patients on how they can prevent it. Somebody in clinic last week asked me, what's the difference between caries, cavities, decay? Is that all of them? Someone asked me. Anyway, they're all the same thing. When I talk to my patients, I use the word cavity because that's what they relate to. That's what they know, and that's what they call it. In a professional setting, it should be termed caries, but those words are interchangeable: caries, cavities, and decay. Okay, so with dental caries, it's important to know that it's infectious, meaning that it's caused by bacteria, that it's transmissible, and it's communicable, meaning that it can be transferred from patient to patient or from person to person. It can also be transferred from spouse to spouse. So those of you that may have husbands that don't like to come to the dentist and they've got cavities, wouldn't be kissing them because they're transferring that bacteria to you. Also, they have found, also they have found that mothers can pass this bacteria to their babies. So if you want to make sure that if you've got a patient in your chair that's pregnant, make sure you emphasize that and let them know that it's important to take care of any of their dental caries that they may have, so they don't pass that on because it is caused by bacteria. Okay, so there's three main components that have to be there in order for a cavity to form or caries to form. There needs to be acidogenic bacteria, which we'll talk about the two most common types that you'll need to know. Fermentable carbohydrates need to be there, and time. And all those three things in their perfect little world creates an acid that is what erodes the teeth or demineralizes the tooth structure. So the two main bacteria that you'll need to know, and these will always show up on the boards, so these are something you really want to make sure you're familiar with these names, are the mutant streptococci family, which is mostly active during the initial stages of cavity formation. This is when the lesion is not really visible to the naked eye. This is kind of that sticky plaque that shows up with your disclosing solution. By the way, Ms. Mendenhall gave you guys all these notes and the PowerPoint, right? So you have all this? Okay. So strep mutans is in the initial stage of dental caries. Then later on, when the caries becomes more active and it's more of a visual lesion, that's where they find the lactobacilli. So strep mutans is first, lactobacilli is second, or is later. That's how I remember that. Lactobacilla later, L-A, kind of helps with those correlations. Okay, so if you have those bacteria present, and you have fermentable carbohydrates, which consist of sucrose, that's like your basic sugar found in our sodas. Glucose, fructose, which is in fruit. A lot of times we think we're eating real healthy. If we're eating fruit all day, we're exposing our teeth to fructose. And then our cooked starches are our breads. So most people correlate candy with sugar and cavities, but it's important that we know that it comes from breads. And also my nemesis in our family is fruit snacks. So when I was a new mom, I thought, oh, fruit snacks, they're healthy, right? I had them in my backpack, I had them in my car, in every drawer in the house. They were like my go-to weapon when my baby needed something, And those are kind of the worst. Why would you think something like a fruit snack is worse than even like a candy bar, a chocolate candy bar? Sticky. It's sticky. It sticks down into those pits and fissures, and then it kind of stays there for hours and hours. And that's where our next one, where time is the third factor. And if it stays on there long enough, it has to be on there a certain amount of time. It's different for every patient or different types of strengths of enamel, how long it has to be on there. But if it's on there too too long, that's when the acid starts to form. Notice I didn't put Diet Coke up there, because of course that's really healthy. We all know that, right? Okay. The acid formation and demineralization process. So I'm going to use this little pointer here. This slide is these white lesions, and where do you think these came from? They're kind of square-shaped braces, very, very common in braces. I'm guessing this patient just got their braces off like the minute before this was taken, because they still have those really swollen papillas. But so that's the initial stage, and we'll kind of talk about the different stages of cavities there. But that's what the first visual clue is, that there's decalcification going on, is those white lesions. Like I said, very common around orthodontics. And then when it's been on there long enough, it gets really white and kind of rough when you feel it with your Explorer. You want to be careful when you're feeling it not to break through it, but it's really, really rough and chalky. And obviously here's where it's broken through the enamel. Okay, so let's review quickly. What are the three components necessary to initiate the caries process? Bacteria, time, and the carbohydrates. And what are the two bacteria? Okay. And which is the first one in the initial stage? Mutants. Okay, so more about demineralization. Look at this one up here. So this is a proximal surface, either mesial or distal, and it looks like a premolar. Where do you think this lesion came from? Interproximal, right? So what would cause that? Not flossing. A lot of times when somebody's had a tooth extracted and you can see that proximal surface visually, you see that. And I like to show those to my patient. I like to get my intraoral camera out and show them to my patient so I can explain, like, this is why it's so important to floss, because that's a very good visual right there. So something about enamel that's important to realize is that it's constantly changing. It's constantly going through a stage of demineralization and remineralization. Acid dissolves the calcium and the phosphate minerals out of the tooth structure, and this is what starts that caries process. So it's important to know those calcium and phosphate minerals, because those are what are leached out during the decalcification process. Frequent bathing of tooth surface with acid causes demineralization to develop into a cavity. So it's that time factor again. That's where those all-day soda drinkers, they think, oh, I fill up I'm doing really good. I'm down to 1 32-ouncer a day. I fill it up in the morning, and I sip on it all day long. But it's only one, where before I would have 4. So that's where your education needs to come into play and let them know that it's better that they take that soda and they down it all in the first 5-10 minutes, even if they have a 62-ouncer. Down it all. It's better for their teeth, maybe not for their organs, but better for their teeth if they don't bathe in it all day long. Let's see, and it's important to know that demineralization can occur in both smooth surface, which is like the straight buccal or lingual, or down in the pits and fissures, which is usually where it happens first, where we detect it with our Explorer down in those pits and fissures. So when we talk about pH, neutral pH is around 7.2, and that's mostly with water, so that's your safe drinking water, that's about it. And then when the acid in the mouth, when the pH in the mouth, hits about 5.5, that's when the caries process can start. If the pH stays around this 7, you're not going to have that. That's one of the factors that you're going to remove from that caries process. So just kind of remember that 7.0 is neutral, 5.5 is what's needed. But something curious on here is look way down here. They're not even on the chart. So energy drinks, sodas, they are very, very acidic. So when you're going over risk assessment with your patients and they admit that they're soda drinkers, that's something you can talk to them about.
They need to put that on the bottle.
Yeah, like a surgeon's warning or something when they put on cigarettes. Yeah.
Terrible.
Oh, I wonder, can these lights go down a little bit?
Yeah.
The far right,
What about this one?
it should far right.
Oh, that one. Okay. Yes.
So on the last one,
Okay.
pH 3.0,
Okay.
second column halfway down, it says lack of sleep.
Ooh,
right there. No,
Lack
I don't.
of sleep.
Craziness. And stress. Overwork.
So hygiene school should be listed right there. Yeah, that is. I didn't pick like on a radiograph. The first thing I want to point out with this slide is look at how beautiful those contacts are. Okay, I didn't take this. No, I didn't take these. But the reason why I point that out is that this is how important it is that your contacts are open. Sometimes, you know, we're kind of picky on your grading because we want those contacts to be beautiful. But this is the reason why, because demineralization will first show up as an incipient lesion is what it's called. And it's this right here where it's just a little bit starting to fade out or starting to get gray in this area and up in here. We want it to look, kind of grainy up there, but we want it to look more like this contact. See how nice and beautiful and solid white that is. This is another thing that I really like to show my patients on their own radiograph when I take it, when I'm talking to them about the importance of flossing. I let them know, because all they hear is, I have no cavities, great, I'm doing everything perfect. And then what's going to happen a year from now when they come back and every one of these incipient lesions has turned into, you know, a DO here, an MO here, a DO here, an MO here. All of a sudden they have 4 cavities, 5 cavities, and they're wondering, well, I was doing everything fine, and we said I was doing anything wrong. So I'd like to point those out to my patients to let them know that, yeah, you don't have any cavities now, but these are knocking on the door. And we'll talk about how they can prevent those too. Look at her, she's so cute. This is my niece, although I've been called her grandma 3 times, and I don't even care because she's so cute and I love her so much. But, so remineralization is basically the opposite of demineralization. It is where the tooth can actually remineralize or reharden. So when you see those incipient lesions and you're talking to your patients about them, you let them know that with proper home care and with the right minerals that are available and fluoride, they are able to remineralize those areas, those initial stages. So let's see, saliva fluoride, yes?
So I'm interrupt.
Oh, hi.
At Table Clinics, there was a presentation showing the acidity of different mouth rinses.
Okay.
And I just think it's interesting because there's like anti-cavity mouth rinses that have the fluoride in it. It's supposed to be remineralizing, but it's actually super acidic, so it's demineralizing. So I thought that was really strange. And
That
I
is,
think it's,
do you remember what the pH was?
I don't remember.
They were like 2 and 3 something.
Yeah.
There is
Really?
one in my
Interesting. Were they ADA approved ones?
yeah, like Listerine. So the only one that wasn't really acidic was like Arm & Hammer Strong.
Yeah, if you ever look at the ingredients in Vitamin C, it's the
Interesting.
same thing, it's really low in pH, it's very strange.
I think it's reckless for the company and for ADA approval.
Yeah,
to-
that does seem like it contraindicates itself.
Yeah, it was my
That's-
hygienist who pointed that out to me, she's like, yeah, I have a hard time promoting this product because they already have dry mouth. So they're already at risk for,
Yeah.
for cavities, and then you give them this that they think they're doing great with, and it's more acidic.
That is interesting.
So the only thing that I can think, it doesn't say directly, but it says that
Are you looking at
remineralization.
that fast?
Remineralization occurs at 7.5,
Okay.
and when you're sleeping, your body kind of balances itself out to where it's supposed to be. So I think the longer you're sleeping,
It gives your body a chance to get to that
Yeah.
7, that neutral pH. Good, thank you. Thank you for doing that. Any other questions so far? Doing good? Okay. Saliva fluoride and xylitol can promote remineralization. Who knows what xylitol? Yeah. So it's a sugar substitute, and it's found in a lot of gums, like Trident. Trident's one of the gums that I like to recommend. So first, saliva. So saliva forms as a buffer for the acid, so it actually can bring the pH back to neutral. So saliva is very important in that aspect. Saliva also supplies the minerals to replace the calcium and the phosphate that was leached out in the demineralization process. Those minerals are already in your saliva, so those go back in and remineralize the tooth. And then it also transports fluoride to the tooth surface. So like when we do a fluoride varnish, obviously we're not getting on every single surface of the tooth, but the saliva in the mouth moves that fluoride around. That's why some patients will be like, well, I think you missed a spot back here, or did you get enough back here? I let them know. Even if I didn't, I'm not going to get it everywhere, but your saliva is going to move it all around and you will get the benefit everywhere from it. Fluoride inhibits demineralization and it enhances remineralization, and it actually inhibits the bacteria in the biofilm, so it actually stops the bacteria from colonizing, so it helps that way too. Not a lot of patients realize that. And then we talked about the xylitol. Xylitol actually inhibits the strep mutans. So, something that I did read was that you should chew 4 to 5 pieces of that a day to keep it constantly in your mouth. I thought that was a little interesting, and then that will help you prevent it from passing it on to another person. So I guess if you can't get your husband to come in, at least give him a piece of xylitol gum before you kiss him.
So I just had a question. I know, I think you were with me when we were working on that
we really? So I think, I don't know, so we gave him a prescription for that,
Prevenant.
the Prevenant.
Right, we'll
How
talk about
long
that.
how long does that take to remineralize the tooth if he's using that every day, 2 times a day? Like, is there a time frame? Because I just saw that, you know, a ton of demineralization, and I'm like,
And you're wondering
I don't know
how-
if we're ever gonna get
Yeah,
back
if
up
it's
to par.
To the point of no return.
Yeah.
From what I understand, I don't know exactly the time frame, but on his particular mouth, most of those were already full-blown cavities. I mean, those were kind of past the point of no return because they were already into the second stage where it's visual. Most of what Prevenant will do will help in the initial stage of the cavity formation, caries formation that isn't visual. Do you have anything to add to that? Is that?
And also, it will help to remineralize areas if they're using Prevenant every day or.
Right, so her question was how long will it take for it to actually start remineralizing?
It just probably depends on
And
the
how far it's
pH in their
been
mouth.
demineralized? And their oral hygiene habits, if they're drinking a lot of soda, but that's a good question. I'm sorry, I don't have an exact,
It's okay.
it's gonna be exactly 27 days.
I'm sure it's different depending on the severity.
Absolutely, yeah, on where the demineralization is, how far advanced it is. Okay, so there are certain things that are required to detect dental caries. One of them is adequate lighting. We all know how important the lighting is. Sometimes with your mirror, you can reflect the light to find the interproximal caries on like the anteriors. That works really well.
Ask them what it's called. What's that called?
So what does it look like then if you're doing that? They go through?
It's kind of like a halo or like a shadow.
You can see it on
You can
the tooth.
see it, yeah, yeah. Which brings up the next one, the sharp trained eye. And that's something that I'm sure if you guys are getting that sharp trained eye. If I showed you this radiograph your very first day in radiology, you'd probably say, oh, those are probably teeth, right? But now that your eyes are getting more trained, you can see those interproximal areas and you're like, oh my gosh, that one's probably getting to where they're feeling that one. We've got maybe over here more of an incipient lesion there because it hasn't quite broke through that enamel surface there. But so that's kind of where that sharp trained eye is. And even now, the patient will say, do I have any cavities? And I'm like, well, looks good to me. We'll see what the doctor says. And he comes in and he points out all these ones. So it's just with time, you just get more of a trained eye. And that's not anything you can just learn overnight, but you'll get that. Blunt probe. So this is not a perio probe. This is referring to like a shepherd's hook explorer, right? So why do you think it's important that it's blunt and not really fine, sharp point end?
You wouldn't wanna poke through them.
Exactly. You wouldn't want to poke through the demineralization. Also, if you're thinking about the occlusal surface and the really deep pit, sometimes with a too sharp of an instrument, and I've seen this happen before where I've done it before, it's a more of a mechanical retention that you're feeling. So you push down in there and it sticks, you think it's sticky, it must be a cavity. But there's a mechanical retention that happens because it's such a fine point that goes down into that fine little groove and it just kind of grabs onto it and then you pull it out. It's not necessarily that there's demineralization in that area, it's just that that instrument was so tiny that it mechanically retained itself. Does that make sense? Okay. Air syringe for drying the surface. It's important to make sure you have a good clear vision so that you can see what's going on there, clear out any of the saliva bubbles that might be covering up something that you can see visually. And obviously biving radiographs. And I kind of talked about this earlier, that it's important that your contacts are open. If these contacts are like on this tooth here, I mean, obviously if you had overlap here, you would still see this here. But if you had overlap in here, you wouldn't even see those incipient lesions, or even if you had overlap here on this full-blown decay, you might miss that if they're overlapped. Okay, so there's basically 3 different stages of dental caries. We have the initial infection, which is where the bacteria has just started there. This is invisible to the naked eye. You won't know this is going on. And I believe this is where that Prevenant is going to help the most, is with the areas that you can't really see. The white lesion is over here where you're just starting to see this right along that buccal surface, or this is, if you run the diagnodent over that, you may get reading that there is some changing, and I know that Ms. Mendenhall's going to go over diagnodent later with you.
Question.
Yes.
So is there
it will stop it from progressing into to an actual,
And do
caries.
you know by the touch, like, is it harder, like, it's obviously it's white, but is it harder compared to what you're saying, that white chalky rough, if it has remineralized?
Is it harder
Is it
after it's
a-
remineralized?
Yes, so then we'll know, okay, they're okay, it's not gonna keep going.
You won't be
hopefully.
able to do much harm on something like this. I mean, you don't want to scratch across it with a sharp probe or anything, but, I mean, you would really need to, you can visually see that. And that's where the Diagonite is great too, because that just shines a light on it, so you can kind of get an idea.
I just also had
Go ahead.
I just also had a patient when I took some calculus off of anteriors,
Okay.
it, exposed a hole of remineralization, so, it's just
A
like,
hole, like so that would be down,
demineralization super bad in his braces.
so that has already gone into the cavitation process then.
Yeah.
Yeah.
Sad.
I was just gonna say with the Diagnodent, the tips that we have are not for this kind of caries, it's only for pits and fissures.
Oh, really?
There's another tip that's flat, that is
Oh, okay.
for, smooth surface caries.
Oh,
So the one that we have is not
it's
designed.
more for the occlusal surfaces
Yeah.
and hits. Okay, good to know. Okay, and then once you've got the bacteria present there and they've been sipping on their sodas all day long, that's when we get this, it breaks through to the cavitation process. And that's when it's more visual to the naked eye. That's when you get your instrument in there and you can feel it kind of sticky. How many of you have had that already in clinic? And it feels kind of like you're sticking your into like a piece of taffy, just kind of, and a lot of times your patients will pick up on that and they'll feel that and they'll go, oh, it's a cavity, huh? They know that stickiness means cavity. And when it's in the cavitation process, it's radiographic.
So after it's like full blown decay, is it still sticky? Cause I had,
Yes, uh-huh.
I had a patient at the care fair and his whole tooth, like, the whole back half of it was just, it was so bad. And I would like just, not really scrape at it, but scrape at it a tiny bit and just chunks were falling off.
Yeah,
But I didn't
once
feel
you
like
get
it
those chunks off, you would find sticky.
Oh,
Yeah,
yeah, I didn't continue on, just like,
yeah.
just leave that.
Let the doctor do that, right? Okay, fun fluoride facts. I showed this to my husband last night and he goes, oh, there's nothing really fun about that, but okay. So, we've been using fluoride in the prevention or in the help of preventing dental caries since 1945. So, when some of your patients are really leery of using fluoride, it's been around long enough that if it was gonna cause anything that is not good for the body, probably would have known by now, right? So I like to tell my patients that we've been using it since 1945, so I think if there was a problem, we would know. 40 to 60% reduction in fluoridated communities. So those areas that have fluoride already in their water, there's a 40 to 60% reduction in the population that live in those areas. So huge, it's a huge number. Reduction in prevalence of caries due to use of home fluoride paste, rinses, and professional applications. So there's a whole, you go down the Walmart aisle and there's just like this huge area of just fluoride rinses and things to help with, and fluoride toothpaste. Fluoride's in most toothpaste. It's pretty hard now to find a non-fluoridated toothpaste. Okay, so we'll review quickly what we just went over there. Demineralization is the process of what minerals being leached from the tooth's enamel.
Phosphate and phosphate.
Calcium phosphate. Did you guys read ahead?
No,
Oh, smart. Okay. What are the three main stages of dental caries?
Initial lesion,
Very good, very good. Initial infection, white lesion, and cavitation. And what role does saliva and fluoride play in remineralization? Okay, buffers the acid. Okay. Right, inhibits the bacteria too. Good. Very good. Okay, now we're going to talk about something called GV Black Caries Classification, and I gave each one of you a handout. Did everybody get one? Because I had a couple extra, so I'm not sure. You guys didn't get one? Okay, let me put these to you. So, GV Black is a person, and he's the one that came up with this classification, which is nice because it's nice to know what area of the tooth actually has the carious lesion. So, and this is used in every office I've ever worked in. This is used pretty much universal. So let's look at what a class 1. So class 1 is only in, it's basically in pits and fissures, pits on on the maxillary anteriors. 7 and 10 usually get those little pits. So that would be classified as a class 1 lesion. Class 2 lesion actually goes interproximal only on posterior teeth. Okay, so it's only in the posterior teeth. It is an interproximal surface that is included. So that would be a class 2. Class 3 lesion is an interproximal only on an anterior. So the 2 and 3, the only difference is what tooth it's on. A class 4 lesion is only on anterior teeth as well, but it actually includes the incisal edge. Okay, so it's it's class 3 lesion including the incisal edge. Class 5 is along the buccal surface. This one I think is used most often because you can tell someone they have an occlusal filling, or you talk to the doctor about occlusal. There's a suspicious area on the occlusal, pretty much knows where to go. But if you say it's on the buccal of 31, he won't know if you're meaning the buccal pit, which would be a class 1 lesion, or along the gum line, which would make it a class 5, or the lingual, so buccal or lingual. And then class 6, you don't see these too often, but this is just the cusp tips on a molar tooth. Okay, and every once in a while I see that, and that's usually not from lack of hygiene or from poor eating habits. Usually that's something that happened when the tooth formed. The enamel just didn't knit real tight right there. That's kind of how I explain it, because sometimes you'll see that in kids. They'll have it right on the pits, or be right on the cusp, and I like to tell the patient, the parents, no, this one really wasn't their fault. This is a really hard one to get a cavity there. So, yeah.
Is our class 6 as well the anterior, like the attrition area, so would it be like the anterior occlusals?
Anterior occlusals? Anterior
Incisal.
they have incisal, so that would be down here on a class 4.
But if it's just the incisal, not.
Oh, it
not
can be
canine.
on just the canine. Actually, if you look at let's look at class 6 caries. This is the very bottom of the handout. Class 6 caries affecting cusp tips of molars, premolars, and cuspids. Okay, so not your lateral or your central, just the canine and back. Okay. Good question, though. Thank you for bringing that up. That would be a really mean trick question.
Yeah, it would.
Okay, so we're going to review some of these together. We have, so here's a carious lesion here. It looks like where is this surface? Class 5, yep, because it's along the buccal or lingual surface. It can be on an anterior or posterior tooth, and this is what it will look like in the mouth. Okay. You're all too smart. Okay, how about this one? Class 1, right? Occlusal or including that buccal pit. What about this one? Class 6. You can see how it'd be kind of hard to, because it's such a cleansable area. It's just something just didn't form right there. What about this one? Class 4, because it includes that incisal edge. And that's what it looks like on radiograph. That looks like it just got chopped off.
I feel like they look like 4s. Like a 4 has like a chop off. That's all I've ever done.
Hey, good.
That's the only way I
One
remember.
down here and then 4. Thanks, Rex. Thanks, good. And what about this one? So not including the incisal edge, but it is on an anterior 3. Very good. And what about this one? 2. So it's on a premolar. Or it can be on a molar, and that's what it looks like radiographically. What's this right here? There's some demineralization going on there. And even a little bit starting right there, a little incipient lesion starting there.
I don't see anything that one. All the others I'm like, yeah, okay. But that
Right
one,
here?
I'm like, yeah.
It's just barely starting to fade out. Look at the difference between this surface and the mesial surface here. See how that's a nice crisp white line? And right here, it just fades just a hair.
Would it be right across as well? It looks like it's a little bit darker there.
Here?
I see the one
Yeah.
across
Yeah,
from
this
it.
one looks a little
Right
more
there,
obvious.
yeah.
Yeah, this one may actually be through that DJ there. So, yeah, good. See, your trained eyes. You're getting them. Very good. Okay, so let's talk about some selective care planning for the patients that do have some lesions that we need to worry about. So we want to plan for restorations if there is existing lesions. So I did want to point out in the beginning that I forgot to mention, we kind of touched on how it's important for the hygienist to have a background in caries. When I was first out of hygiene school and I moved up from St. George up to here, I was temping in a lot of offices and I was trying to find work, and I ended up temping for an office whose hygienist was out on surgery. So he was using a whole bunch of temps, and I ended up working for him, and I still work for him 14 years later. And I asked him, what was it that you gave me the job? And he's, besides my charming personality, was that I was trained by my previous doctor. I worked for a year out of hygiene school for a doctor that pretty much had the hygienist do the exams. And legally we can't diagnose, but we would go through and we would find everything. We'd use the diagnodent, we'd use the intraoral camera, we would show the patients everything, talk to them about what restoration they were probably going to expect with that type of lesion. So that the doctor came in, he was very, very busy, he ran 12 chairs, crazy. But so he'd come in and he was like a 2-minute exam. He'd come in, what'd you find? And we'd go through and I'd tell him everything and he'd just say yes or no and then he'd be done. So I was kind of trained like that, and I came here to Salt Lake and that's just what I did. And he said that's what he really appreciated, is it saved his time from having to educate the patient on why they have a cavity, how it formed, what restoration is going to be needed. So although we can't diagnose, we can educate and we can talk about suspicious areas that you see, and that it could possibly be this, and if it is this is the restoration that he'll talk to you about. And then the doctor comes in and just says yea or nay, and they really, really like that. And when you girls get out, it's very competitive, as you know right now, and you're going to be competing for a spot. So if you're competing against someone that has exact same skills and the great charming personality, this is something that may put you over the edge in a working interview. This is something that, your x-rays, we always tell you, are your first impression. What you find in the exam could be your second impression and could get you the job. So I encourage you to really start looking for that in your patients in clinic, and kind of having things written on a sticky, so when the doctor comes in, you can say, I think there's something here, check out this surface here, so that you're kind of guiding the doctor through the mouth. They really like that.
Yep. How are you able to do, I know that some of the stuff that we do in clinic is not usually done in private practice, so how are you able to do the probing, a full cleaning on a class 2, class 3, and an entire diagnodent, all the, and you said the intraoral camera, how are you able to do all of that in 30 minutes?
You just get faster at it.
In
Think
30
of
minutes.
the first time you put on a full face of makeup, okay? If you had to wash your face, you had to put on your primer, your moisturizer, your blush, your mascara, your eyeliner, all that. The first time you do that, it takes a while. But how fast did it take you to do it this morning when you had to be in class at 9?
3 minutes.
Yeah. So you just work up to it. It's just experience.
Yeah.
You just work up to it. Wouldn't you agree?
That's a great analogy. Except for me.
Let's see. So preventative planning. So you guys all know the risk assessments sheets that you have in clinic, and you've been using those. So those are really helpful to find out how high of risk that your patients are at, and to offer certain things that can help to prevent the dental caries. And we'll talk about some of those things here. And we stress OHE, OHE, OHE all the time. That's because if they don't get it from you, they're not going to get it really from anyone else. So make sure you're educating as much as you can. And you've got a captive audience there. Your hands are in their mouth for a whole hour, or here, or 3 hours. You've got a captive audience. Take advantage of that and teach them specific to what's going on in their mouth. If you've got a patient that has no cavities, don't spend your time educating on cavities. Spend your time educating on something that might be more beneficial to them. If they said they're drinking a lot of soda, talk about that more. So make it customized to your patient. Okay, so a risk factor is a habit, a behavior, a lifestyle, or condition that increases the risk of a disease. So I put some of these pictures up here. Obviously your habits, your eating habits, huge. If you're nibbling on stuff all day long, grazing is what I call that, then you're constantly bathing your teeth in carbohydrates that can make it more susceptible to decay. Medications, what role do you think that has? Where does that? Aerostomia, yeah, it dries the mouth out, absolutely. It's not necessarily the medication that causes the decay, it's the dry mouth. Truck drivers, if someone tells me they drive truck or they tell me they sit at a desk job all day, I always ask them, what do you drink? Because most of the truck drivers, they're drinking a lot of the energy drinks, and they sip on it all day long in their truck, and it's constant exposure, or the secretary that sits at her desk or his desk and has constant exposure. So you want to kind of feel for those risk factors that your patient might have, so you can again tailor it to their lifestyle. If you look on page 381 in your book,
We don't bring that.
you don't bring it too heavy. Okay. kind of is a guide on it, what is a high risk, low risk, moderate risk, severe risk for caries. Okay, caries management. We talked about this a little already. Determine the restorative needs of the patient. You'll want to kind of know what types of materials your doctor uses. If he prefers a PFM crown, if he likes all porcelain, if he likes the zirconium crown, if he does use amalgam sometimes, you know, there is, believe it or not, a place for amalgam sometimes. Some doctors don't use it at all, but you kind of want to be on board with your doctor and have the same beliefs as them so that you're not talking to your patient about a feeling that the doctor's going to come and say, oh no, I don't do that, because then he's going to discredit what you just said. So you kind of want to get on board with what your doctor does. Identify areas to remineralize, so look for those white lesions, and initiate a remineralization program. There's personal fluoride rinses that they can get over the counter. There's dietary modifications you can talk to them about, and then you know, xylitol gum. We keep xylitol gum on the counter at my office so they can grab some on the way out. It's a great way to bring up xylitol because they always say, "Ooh, what's this?" And even our front office manager knows all about it. She can educate them up front too.
Yes. Something I found out really exciting, also table clinic name was Stacy. The xylitol gum, like just, I know you can like buy, I forget what it's called. But you
Trident has it.
It's the ice cubes.
Right, so you
Oh,
can
ice
buy
cubes.
like an actual brand though that has
Oh,
Sprite.
right.
Yeah.
Right, that's what we have.
Yeah, so
The
but
little
if they just
packets.
wanna go to the store, like wanna pick up some gum, there's xylitol, but then there's also the Icebreakers ice cubes, and it has, those ice cubes have more than xylitol. The brand name, it's Icebreakers.
Has more than the Spree.
It has more than Trident.
Oh.
Which I didn't know. I've always been
okay.
chewing
I didn't know
Trident.
that either.
The ice cubes and
Have more xylitol.
Mm-hmm.
You know how much more?
I don't, I
Like
can get up.
0.003, so they can say that they have more, or is it? Look that up.
Those have the most of any commercial now.
Good to know.
Not
And they've
Spry.
got to last longer. That Spry gum, when we get that and we hand it out, but it's good for about 30 minutes. And then you're done. That's done. And it sticks to restorations too.
Yeah,
I
it's
don't know why.
sticky.
I know. Someone didn't think through that one. Okay, so we have some professional applications that can help with your patient that is at high risk for caries. Chlorhexidine rinse, when you think of chlorhexidine, you think of what? Perio. Yeah, you think of treating for perio. And sometimes even I still forget if somebody's got rampant caries, you know, the first thing I think of is Prevenant when I think of giving them something that's a prescription to help with their caries. But you can use the chlorhexidine rinse because it is effective against strep mutans, which is the initial bacteria that causes it. So if we wipe that away, then their risk is diminished significantly. So keep that in mind as somebody who has rampant caries. I can tell you we don't use that a lot on someone that just has a we find one cavity every couple of years because that's kind of what overkill. This is from someone with more rampant caries. So what about Prevenant? What patient would be good for Prevenant?
Like leprosy.
Yes. What about those incipient lesions that we see on the radiograms? Absolutely. But if they're just going to brush it on and spit it out, what is that going to do much for those incipient lesions? They got to get it flossed in between. So the directions for that is, you brush it on, spit it out, floss it really good throughout, but then don't eat or drink anything and just go to bed.
How effective is the floss that has fluoride in it?
Well,
I feel
it's
like
probably
if you're-
better than nothing, but it's not going to be better than Prevenant.
Right. So how long do you think it would take if someone was using, maybe not quite a chlorhexidine rinse, but even
To remineralize?
yeah.
I can tell you that in my office, if my doctor has an incipient lesion, if I point that out, he'll say, let's put a watch on that. So 6 months later that this patient comes in, I take a new biving of that area, and we have seen it in 6 months remineralize. I don't know how soon it happened in that 6 months, it happened in weeks, but within that 6 month period, we see remineralization radiographically. Yes?
The MI paste, is that not?
You know, I should know more about MI paste. It's not one that we push in our office or that we carry. So I think that is more for the white lesions. I know that. Do you have a rep that comes in and talks about MI paste or anything? We don't. Do we push it in the clinic really? It's mostly the Prevenant. So I'm assuming that because we push that mostly, it's probably more effective. But that is something we could look into.
They have the new MI paste plus software.
Oh, really? I'm not exactly sure what the ingredient is in MI paste that makes it different than.
And what, like, MLC for the fourth and the fourth?
fluoride varnishes that we offer.
Love those.
Yeah, they're so great. Some of you don't remember the day. Well, I guess you guys do have to do the tray ones, but where they just drool everywhere and then they can't eat and you don't want them to do anything to even talk because you don't want it to come off. The varnish is great. There is the downside to varnish. You know, they feel like they need to go get their teeth cleaned after you've just cleaned it and put them on. But the fact that it is a varnish keeps it on the teeth for up to 4 hours, so they're able to leach out the fluoride for the whole 4 hours. So I love the varnish. I like it for kids. I like it for adults. I like it, you know, for all ages. And then sealants. You guys do a whole separate thing on sealants, don't you? Should we touch more on that? Okay. The one thing I do want to point out with sealants is sealants only prevent decay if they're placed correctly. If they're placed incorrectly, they can actually cause more problems. And that's something that I didn't really, I'm sure I was taught that in school, but I didn't really pick up on that. If you just slap a sealant in there and it's doesn't have really good clean margins, and it's kind of lifting in an area, and you've probably seen that in patients that come in with a sealant and there's a bunch of stain around it and it looks terrible, that's at more risk because that bacteria can get in between the sealant and the tooth, but their toothbrush can't get in there. So you want to really, really make sure, I know on your LEs, some of you have been doing PEs on them in clinic, and we stress, we make sure you do the 20 seconds drying, 30 seconds drying in between, and that's just so that we get that really good seal, so that we're actually inhibiting decay and not encouraging it.
I think that's where the misconception comes when people think then I don't want a sealant, because they seal in the bacteria.
Right. So they just have to replace. In fact, I'll tell you in my office, I don't place sealants. The doctor does all the sealants. And he uses air abrasion, and he cleans it out. He uses the drill and opens up any pits and fissures that look like might be suspicious to him even, and he just makes sure that it's all cleaned out, and he places the sealant material. So, and he actually places it not with sealant, he places it with composite. And
Oh,
just,
wow.
yeah, because at first, I said, you know, when I first started working for him, you know, I list, you know, your whole list of I can do this and this and this and this. And he said, well, we don't really, I place all the sealants here. And I thought, he's crazy. Why isn't he having me doing that, you know? But now I know why. I mean, his sealants are awesome and they never come out and they never have recurrent decay under them, so. Any questions on this?
Would we be able, would we be able to place composite as a sealant?
No.
I didn't think so.
But there's glass ionomer sealants that you can place though.
We can't.
And those
Those are
are,
fluoride
we've talked about those a
releasing,
little bit, yeah. And the working time is really short and they don't have to be perfectly dry, but the delivery method is really flawed. It's really hard to do. It's hard to move fast on them.
Okay.
And so that's one of the problems because I,
You mean a hygienist can do the glass ionomer? Oh, okay.
Yep.
Didn't know that.
Yep.
Yeah. So anyways, yeah, so that's just a little FYI on sealants. Okay, and then more OHE. Just make sure you're informing your patients of, make sure that they understand what causes the cavities and how they develop. If people understand what's going on, then they're more likely to know how to fix it and they're more likely to do what you say. Just yesterday was Tuesday? Yeah, I had a new patient in my office and she was complaining of a sensitive tooth along the buccal of number 3. And she had a little bit of recession there, and so, I said, how long has it been bothering you? And she says, I remember 8 years ago, this is the first time I mentioned it to my previous, I've been to several dentists, nobody can tell me what's wrong. I know something's wrong, they take an x-ray, they say everything's fine, they don't do anything, but somebody's missing something. So here she is shopping around for the dentist who's gonna cure this sensitivity, and I just took the time to explain to her. I remember when the rep came in and said, how many tubules are in a square millimeter? Like 35,000 of them or something. So I just took the time to explain to her what was going on scientifically in layman terms, like so that she would understand what was going on right there, and explain to her why sometimes it comes and goes, why sometimes it's more severe than others, why it doesn't show up on x-ray, you know, why nobody's done anything, why nobody's filled it or whatever. And she's like, I'll do a root canal or whatever, I'm so tired of having this. So, but once I explained it to her, she goes, nobody's ever explained why it's doing that. I just thought this whole time that everybody was missing something. So just take the time to really explain what's going on for your patients so that they know that, you know, then if it makes sense to them, then like, oh, okay, well, I guess I'll stay here and not go find another doctor that's gonna maybe fix my problem or that will find what's going on. Yes?
So I found it.
Oh, okay.
So the ADA has, that they approved, the ice cubes, ice-breaker ice cubes, and everyone knows what it looks like, right? They're in the little like car but the icebreaker ice cubes have 1.15 grams per cube of xylitol,
1.15, okay.
and Trident has 0.17.
Wow. Wow. So that's like 6 times maybe?
And
Wow,
then there's
great.
like Mentos Pure, Mentos, the Up to You Mentos.
Mentos has it? The fresh maker?
That's
Remember those commercials? You might be too young, you know it. Mentos, the fresh maker. Okay, good, thank you. So it is a significant amount.
Yep.
Okay, good, good to know. I will now recommend ice cube icebreakers. Okay, so make sure they know how to remineralize their carious lesions. Let them know that cavities can be prevented. Talk to them about that there are really only 3 things that the tooth needs to form a cavity. If we just take away one of those, then we're going to inhibit that caries formation. Talk to them about the benefits of fluoride, the importance of regular dental visits, and a lot of times patients are leery about getting radiographs, as you've probably noticed in clinic already. And so this is something that, too much radiation is too much radiation. It can be like anything. If there's too much, then it can cause problems. But I had a patient on Monday who really, he says, my mother's got cancer, my father's got cancer, my brother's got cancer. I get x-rays all on my back because I got back issues. I don't want any x-rays. So I said, okay, well, the problem is you haven't had them for 2 years, and he's got tons of restorations. He is pretty high risk for caries. Almost every time he comes in, we find something. And I said, the doctor can come in and look and clinically see, but without an x-ray, we can't see what's going on in between or starting underneath your crowns. And so he gave in and let me just take 1 vitamin on each side. And sure enough, under the mesial 31, there was decay starting underneath his crown. And it was actually pretty good size. I probably would have found it as I scaled in there anyways without the radiograph, but it was good for him to see why it's important to have those radiographs on a regular basis, especially if you're at high risk, because you just can't see in between the teeth. He'll still fight me on it next time, I'm sure. And then number 6, make sure that they know that the reason why you're telling them all this, the reason why you're jabbering to them and telling them they should do all these things is because you care about their overall health. Because you care about them, you want them to be healthier, and you want them to lead a happier life. Studies have shown that people who get into dentures earlier lead a less fulfilling life, have a shorter life, and it's all because, we all love food, right? We all want to be able to eat our food, and it's so satisfying to be able to chew your food, and if you have dentures and you can't do that, why live if you can't eat? My motto.
Tell everyone.
So all you need is love and dentistry. That's the moral of the story there. Okay, quickly we'll go over and food. Thank you. I should add that. Documentation. This is important because how many times have you guys gone into a doctor for whatever reason and you explain all this stuff that's going on, and then you go in for a follow-up visit and you have to re-explain everything you just talked about the last time. You kind of feel like, well, did you not care enough to document what we talked about so that you can follow up with me? Or just the opposite, you go in for a second time for a follow-up and they say, okay, it looks like last time you came in you had this and this and this, and how is this working out? We talked about this, how's that working out for you? It's like, oh, they're actually keeping tabs on me. They're gonna, I'm gonna listen more to what they say, I'm gonna follow more what they do because they actually care if it's working for me or not. So make sure you take good documentation. If they ever say anything like, I hate flossing, I never floss, I write that in quotations in the chart. They stated, quote, I hate flossing, I never floss. Because if you ever have to go to court for something, which luckily I've never had, and hopefully you never have to, but if you have that in there, that's documented exactly what they said. Indicate oral care and dietary recommendations. Just indicate. Talked about patient drinks soda all day long. Encourage patient 1 a day and consume in less than 5 minutes. Something like that, so that you can talk to them. I know you still have your soda. You're able to do it in less than 5 minutes. Be specific in your documentation. Reevaluate a follow-up at each visit, and then make sure you record what the patient says in the comments. Questions?
Can they brush instead of rinse with water after they use Coke or something? I think that's not right. Soda.
Can they
Because usually, they say like
to rinse out afterwards?
Should they just?
Well, brushing would be ideal. That would
I
be
just heard
definitely
it,
better.
I'm sure it's a myth, but that you're supposed to even wait after you eat to brush, maybe like half an hour. Don't remember the reason.
Something about spreading acid.
Well, because of the acid.
Dr. Hobbs or
Oh,
Dr.
really?
Olson told us that.
I don't.
Really? I think, I don't know.
After you drink something, throwing up, that's what it was. It has, was really acidic.
Yeah.
You should wait
know, if you have a patient who's pregnant or bulimic and if they vomit, you don't want them to brush their teeth right away because the acid in their mouth can actually cause more problems with the enamel. They wanna drink some water and bring their pH back up.
Okay.
So, yeah.
Oh, interesting, I didn't know that.
Because when they have an acid, I call it an acid attack. So with their sugar, or if it's some kind of an erosive material, the energy drinks, it attacks their teeth for about 20 minutes.
Okay,
And
so you wanna
so-
wait till that pH gets
Neutralizes again.
neutralized and then.
Yeah, and the saliva helps with that, but if they can drink some water, that'll, bring it back quicker, so.
What about drinking milk?
Well, milk,
Milk has a lot of sugar.
yeah, milk has a lot of sugar in it, so that's kind of another acid attack.
Like food in general. I heard that.
Just stick with water.
Yeah.
Water